The Washington Manual of Surgery podcast is based on the 9th edition of the best-selling Washington Manual of Surgery.
This podcast is meant to condense key topics from our manual into bite-sized episodes for your convenience. Now, on to this installment of the Washington Manual of Surgery podcast.
Hello, everyone, and welcome to the Washington Manual of Surgery podcast. We bring you everything you need to know about high-yield general surgery topics built for your just-in-time learning. On this episode, we are thrilled to have Dr. Surendra Shenoy here to review the management of all things vascular access.
Thank you. Thank you for having me here.
Dr. Shenoy is a transplant and vascular access surgeon at Washington University in St. Louis. My name is Fatima Mustansir, and I am one of the vascular surgery residents and will be your host for this episode. Approximately 1 in 15 individuals have a risk of developing end-stage renal disease during their lifespan. While renal transplant and peritoneal dialysis are used as modes of renal replacement, they are at risk of failure. The chances of surviving an ESRD or end-stage renal disease lifespan without being dependent on hemodialysis at some point are remote. Our patients' quality of life and longevity on hemodialysis depend on the quality of dialysis they receive, which in turn is dependent on how well their dialysis access functions. Vascular or dialysis access refers to a site or device in the body which provides access to a patient's blood to deliver adequate flow volumes for dialysis. Among the 3 types of access that are hemodialysis catheters, arterio-venous grafts, and arterio-venous fistulas. Arterio-venous fistulas and grafts are recommended to provide long-term dialysis access. The main goal of hemodialysis access planning is to provide lasting access, needing the least amount of subsequent interventions that can serve a patient's ESRD lifespan. While forearm radiocephalic fistulas are considered the best access, arteriovenous fistulas at other sites or even AV grafts may have to be considered depending on the patients. Current guidelines stress on the importance of understanding the patient's needs, available ESRD modalities, and being able to tailor a dialysis access plan for each patient. For an access surgeon, a clear understanding of peripheral vascular anatomy and options available to create vascular access based on patient presentation is critical. It is important to know the short and long-term complications of vascular access and their management. Today, we will talk about evaluation and management of an ESRD patient, especially focusing on commonly performed procedures that are relevant to both general surgery and vascular surgery training. So, Dr. Shenoy, let's dive right into a case scenario to guide our discussion today. We have with us a 57-year-old gentleman with a history of insulin-dependent type 2 diabetes, hypertension, who has recently started hemodialysis using a tunnel dialysis catheter 3 times a week. He comes to your office in need of permanent vascular access. What are some of the things you would like to know on a history and physical?
So permanent vascular access, arteriovenous fistula or arteriovenous graft, should always be considered as a blood flow circuit, starting from the left side of the heart through a peripheral artery going into a vein or a graft, which serves as a cannulation segment for needling during dialysis, then flows into the peripheral vein to the central vein. For access to function well, all these 5 components, that is the heart, peripheral artery, vein, which is the cannulation segment, peripheral outflow and central outflow, should function well. So when you consider a history and physical, in the history, things to look for is things about these 5 components. For the heart, you look for history of congestive heart failure. For arterial health, you look into the patient history of smoking, which are risk factor for vascular disease, MI, history of carotid disease, intermittent claudication, and so on. When you talk about the veins, you can ask the patient if they have been admitted to the hospital multiple times, have the multiple IV needles, or even in the history, drug abuse history using IV needles. For peripheral and central veins, one has to look into indwelling devices such as PICC lines or central lines, catheters, or cardiac pacing devices. Wires going into the vein can cause stenosis and thrombosis. For physical exam, mostly it allows us to evaluate the peripheral vessels. For the veins, it's important to remember how to distend the veins because you can easily miss the veins which are non-distended. Use of tourniquet, use of warmth, tapping the vein, using gravity, or some of the maneuvers which can use to distend the veins. When it comes to arterial exam, we essentially look for the pulsatility and stiffness of the artery. Of course, checking bilateral blood pressure allows us to sometimes unearth the central stenosis issues in the arterial side. So these are some of the issues we can use to evaluate the patient in the history and physical exam, that is clinical examination.
Is there any additional imaging that you would like?
Yeah, of course, because physical exam has its limitations. When you look at the veins, you are talking about distensibility and patient's body habitus. And when it comes to arteries, both pulsatility and stiffness are very subjective. So point of care ultrasound, there's duplex ultrasound, has the advantage of providing detailed anatomic and sometimes some physiologic understanding of the state of the vessels. So when you evaluate the arteries, you can check for the size, wall thickness, any wall calcification, any luminal stenosis. All this can be figured out. Up to 20% of the patients have anatomical variants, like brachioradial variation, where the brachial artery can divide at the level of axilla. Ultrasound can pick on these things. With proper evaluation, we can use proximal radial artery to provide the inflow for up to 90% of the accesses, maybe it be AV graft or AV fistula that we create. As you know, for dialysis, you require a flow of about 150 to 500 cc's blood going to the machine in a given minute. Now, using an artery that is more than 2.5 millimeters in diameter, like a proximal or distal radial artery, can easily provide a flow of 4 to 500 in the axis. When it comes to venous side, forearm cephalic vein and upper arm cephalic vein can actually provide the outflow for over 90% of the AV fistula. So in our practice, we create radiocephalic fistula at the wrist or at the snuff box in about 70 to 75% of patients. Another 10% of patients may be having upper arm brachiocephalics. Maybe a small percentage, 10 or 15%, may have land up with AV grafts. So when it comes to AV graft, we use a forearm loop configuration using proximal radial artery for the inflow and deep brachial vein for the outflow. Most patients who do not have superficial veins in the forearm to create a fistula tend to have good deep veins. So we consider using them at the level of the elbow, at the cubital fossa. We generally avoid tapping into the upper arm large caliber arteries like a brachial and axillary, unless we do not have any options for forearm access. So ultrasound actually has emerged as standard of care to evaluate the peripheral vessels. But when it comes to central vessels, if we suspect a central problem in the central vein, venography is probably better than ultrasound. We routinely use ultrasounds in evaluating the patient in the clinic as well as during performing these procedures in the operating room.
What do you expect will happen with our patient in this scenario?
So our patient is young with hypertension and type 2 diabetes. He started dialysis recently. More than likely, he will have a good forearm cephalic vein and a reasonable size radial artery available to perform a radiocephalic fistula at the snuff box or at the wrist. Now, if the artery for some reason is totally calcified or not available, narrow caliber, or vein is being destroyed due to previous instrumentation or something like that, I will look at his elbow carefully to see how his state of superficial and deep vessels at the elbow and look for the upper arm cephalic vein. If the cephalic vein is available, we'll do upper arm brachiocephalic fistula. Obviously, we start off with a non-dominant limb first. Now, if that is not an option, we'll consider a forearm loop graft using proximal radial artery and a deep brachial vein as the outflow. And proximal radial artery, as you know, has got usually less calcifications and provides good enough flow, avoiding distal ischemic problems.
So, Dr. Shenoy, how do you intend to perform these procedures?
Procedure of AV access creation, especially fistula creation, is considered simple but has a reputation of having high failures, quoted up to 20 to 58%. And around 20 to 30% of the AV grafts fail within first 6 months. Many of them, of course, due to infection. So we perform these procedures under local anesthesia with some monitored anesthetic care. Some recommend using regional analgesia, which has the advantage of ablating the sympathetic tone and allowing the veins to distend further. We routinely use intraoperative ultrasound, first to evaluate the vessels, find where the artery and vein can come together to plan an incision, mark it on the skin, and mark ultimate configuration of the anastomosis on the skin. With the marking, we plan an incision. Usually it's a curvilinear incision, which allows us to get a larger exposure with small incisions. Since the cephalic vein is directly under the superficial fascia, we'll be able to get that plane of superficial fascia, which is a avascular plane, and create large pockets to identify the vein and to mobilize it. We use what is called the piggyback straight line onlay technique, which actually provides the best hemodynamic configuration at the anastomosis, blood going from a circular to circular lumen. And this reduces juxta-anastomotic stenosis, which, by the way, is one of the major reasons many of the accesses fail. Conventional techniques in the textbooks, we see end-to-side technique. So when it comes to the grafts, it's a similar technique we use. We mark it, we use the ultrasound, we dissect the vessels carefully, but two things tend to be very, very important. One, avoiding infection. We have to be impeccable with sterility, because once the graft is infected, it most of the time lands up coming out sooner than later. Second thing about the graft is tunneling technique. Graft has to be tunneled subdermally, not too deep, and provide nice, long, straight segments so the nurses can cannulate. Doing a loop configuration allows you two long, straight segments, one for the vein and one for arterial cannulation.
So once this procedure is complete, how would you follow this patient?
These patients, we would like to see them early, around 10 to 14 days, mainly to assess the surgical complications like wound infection or wound dehiscence and things like that. But procedure-related complications are also important. Any nerve injuries, or more often, patients can have symptoms of distal vascular insufficiency. So if there are any concerns, we immediately work it further with ultrasound. But if everything is good, we ask them to encourage them to exercise their hands and bring them back in 4 to 6 weeks to see how the fistula is maturing. If the fistula outflow vein is at least a 10 centimeter long straight segment, which is less than 5 millimeter deep from the skin and has a flow of around 400-500 cc's of blood in the brachial artery, we say it's mature and release it for use. This was loosely termed as a rule of 6 in the past. So, but if there are any issues like the outflow vein is too deep or outflow vein is branched, we can superficialize the vein with a surgical procedure or enhance the outflow vein. If the vein is too narrow, at that point we can consider sending them to interventional to dilate the vein to meet the size criteria. If the arterial blood flow is low, we can consider dilating the artery. But it's important to follow these patients up early enough. That way we can come up with interventions to help the fistula mature. I'd like to spend a couple minutes talking about distal ischemic problems. Symptomatic ischemia to the extremity distal to the vascular access can happen under two circumstances. One, when there is too much blood flow going to the access. This is easy to manage because we can identify the inflow and try to place bands. We call it a precision banding to reduce the blood flow in the access using intraop ultrasound guidance. But if you start getting ischemia in the presence of low blood flow just enough to maintain the access, then one has to consider distal revascularization procedures. The most common one we use nowadays is called proximalization of the anastomosis, or otherwise called PIA. And earlier, we used to use a procedure called drill, which essentially provided the same physiology, but proximalization allows us to do this without risking the native vessels by doing interval ligation. It is important to manage symptomatic distal perfusion problems, to diagnose and treat them, to prevent any limb loss.
So, Dr. Shenoy, I've sometimes seen some of these dialysis access patients with large aneurysms, specifically in the cannulation segments. Does this happen with all forms of access, and how would you manage these?
Oh, it's interesting you should ask this. But both grafts and fistula can develop aneurysms. Aneurysms are usually seen when there is a high flow access or mostly high pressure access. The blood leaks out of a graft cannulation site injury, gets collected under the surrounding tissue, and we call this a pseudoaneurysm. So pseudoaneurysms are common in grafts, whereas in a fistula, when you cannulate a high-pressure fistula, the healing takes place, the scar tends to dilate a little bit, so over a time, you start seeing large dilated true aneurysms in the cannulation segments. Now, aneurysms can thin out the skin above them, and the thin skin, when you cannulate, can have subcutaneous hematomas, which can ulcerate and bleed. Bleeding is a catastrophic complication. So sometimes you can have clots within the aneurysm. There's chronic thrombi can get infected. So any of these complications, if you think they're going out of hand, aneurysms can be arrested by cannulating the axis in other places other than aneurysm. And once you've arrested the area, you can repair the aneurysm by excising the aneurysm and reconstructing the underlying vessel and trying to give a good skin coverage. Many of these procedures can be done even without using a bridging catheter. So aneurysms can be repaired. Important thing to remember about aneurysms is that if you can identify the aneurysms, even though if they are not at immediate complications, you can actually train the dialysis staff to cannulate them through healthy areas of skin and avoid cannulating the aneurysm and keep observing them. More importantly, you can actually prevent the aneurysms from happening. If you see early aneurysmal changes, you can try to figure out what is the underlying cause, like a high flow or a high pressure outflow stenosis, and you can manage them.
Dr. Shenoy, that's been very educational. I think we've covered a lot on this topic. Do you have any final thoughts related to hemodialysis access and our discussion?
Patient education and counseling. I think obtaining patients' buy-in into ESRD life plan is the most important critical step. It's important for all the members of ESRD care team and the surgeon to make the patient understand the importance of having a low flow distal access that can outlast the ESRD life. Access surgeons should master the skill of creating functional radiocephalic fistula. And this is possible. We already have practices in US which have achieved this. In a larger scale, countries like Japan have maintained over 90% prevalence rate for forearm fistula for years. It does not matter if the patient is on peritoneal dialysis or has a working transplant. A low flow access is innocuous and will be available as hemodialysis need as a backup. It's also important that every patient and their access should be examined by someone who is knowledgeable enough to identify any issues that can precipitate problems and proactively manage them. I have a lot of patients with a functioning fistula, functioning PD catheter, or functioning transplant who periodically come to the clinic for access monitoring. And I've seen several of these patients on transplant or PD having successfully used their fistula when their alternate modality of treatment failed. So, a well-functioning, low-flow vascular access is the lifeline for the longevity and survival with end-stage renal disease.
Well, thank you so much, Dr. Shenoy, for being with us today and for that interesting discussion. We got through a ton of great information about hemodialysis access. As always, if you're looking to learn more, you can check out some of the literature we referenced in today's episode in the show notes, and a full review of hemodialysis access can be found in the Washington Manual of Surgery.
We are Drs. Paul Wise
and Jeff Blatnick,
senior editors of the Washington Manual of Surgery. We'd like to thank the residents and faculty of the Department of Surgery at Washington University Medicine, and we'd especially like to thank our associate editors for this edition, Drs. Catherine Caldwell, Ina Chen, Bradley Kushner, Martha Bucky McGilvray, and Jorge Zarate Rodriguez.
We hope that you enjoyed this episode of the Washington Manual of Surgery podcast. For more comprehensive information in a brief outline format, check out the print and digital version of the Washington Manual of Surgery, published by Wolters Kluwer Health and Lippincott Williams & Wilkins. Please search online for the Washington Manual of Surgery 9th edition to purchase your copy of the manual.
To learn more about the educational opportunities available in the Department of Surgery, please search General Surgery Residency at Washington University School of Medicine in St. Louis.